I hope I can do this talk a bit of justice. I didn't get to spend as much time as I wanted, but hopefully that kind of stirs some feelings for you guys, positive and negative. But this is meant to be a bit interactive, and I'll start asking questions here and there, maybe pick on some folks. The good news is this talk is pretty much about how we're always wrong. And so it'll be no right answers. I mean, there's some answers that are traditionally correct, but don't worry about the pimping part, because this should be hopefully a bit more fun. There we go. So my only disclosure is I get paid here to try to do my best to treat this disease and to teach you all about it. So I have significant financial interest in this. This is pretty much the theme of the talk. This is a quote from Voltaire. And I want us to try to lean into this a bit if we can. So it's uncomfortable facing doubt. But when we're certain about things, that's something that we should probably be a bit wary of. So let's get a little unpleasant and try to avoid the absurd if we can this morning. We'll base this around a fictional patient. We'll call him Ian, last name Contrary. And so they're starting to question everything around them, and they think it may be glaucoma. So we'll start just by doing the basics. We're doing a glaucoma evaluation, but what's their vision? So let's start with our intern, Cody. So Cody, this is an easy one. Literally, what do these numbers represent?
There's a standard, the average person, what they can see at 20 feet. This person can see at 25 feet on the left and 30 feet on the right.
Correct. And do you know the name for the chart that this is based on?
Snellen chart.
Snellen chart. Okay. And how accurate is it? Let's say something. Let's say their left eye was 20/40 last month, or 20/20 last month, and now it's 20/30. Is it worse?
There can be some variability, I would imagine.
Okay.
Day to day, appointment to appointment.
So you're not certain it's worse, even though it's 2 lines. Okay. Well, very, very good. So this is.
Only interrupt.
I'm sorry.
I think you said that backwards. So yeah, did everybody else hear that too? Okay, yeah.
So sorry.
No, that's okay.
So it went from 20/20 to 20/30. So there's a 2-line difference. So sorry. So
No. But what Cody said was that this person could see at 25 feet what the normal person could see at 20. It's actually the opposite, right?
yeah.
Yes.
Okay.
That's
Yeah. That part backwards. Sorry. Yes. So
Sanders.
and please, everyone, feel free to interrupt, especially the glaucoma folks. I'm going to say things wrong, and then if you have things to add to it, please. This again, I want it to be interactive. So thank you, Dr. Sanders. So this is Hermann Snellen, who in 1865 developed the Snellen chart. It's the same. It's these 170 years later. And this is the prototype we oftentimes see here to the left. It's geometrically based, which means that the 20/20 line is half the size of the 20/40 line, and so on and so forth. And as you can already tell, there's probably some things that should stand out as concerning about the chart that we use. It's the most widely used across the world on a daily basis. The spacing between the letters and the spacing between the lines is not uniform. The number of letters per line is not uniform. So when we say it's 20/20 minus 3 or 20/40 plus 2, those minus and pluses are pretty much inaccurate if we want to follow that for any kind of statistical purposes. The letters are not all uniform. Some letters are consistently easier to read than others. I think it's like T and A, I forget. But anyway, some of them are easier and some of them are harder. And so for these reasons, there's concerns, and there have been repeated concerns about the validity of the Snellen chart in both clinical and importantly in research applications, despite being the most commonly used chart for over 150 years. And so that's, for those of you familiar, that's where the ETDRSs come from. That's utilized in some research studies, but a lot of research still utilizes Snellen for purposes of reporting vision. Is anyone familiar with how Snellen's generally adjusted to try to be more consistent in research purposes? Like we don't report 20/30, report a different number. It's called the logarithmic. As I mentioned at the start, this is geometrically based. So this is not based on a logarithmic scale. So that off the start should tell you that when we report logarithmic acuity, there's going to be some limitations. So taking all these things into account, multiple studies have confirmed roughly the same thing. And that's that based on the variability, you need about 3 lines to have a significant change in vision that's reproducible. 3 lines of vision, which is quite a bit. And it's quite a bit different than I think what we're adjusted to or what we try to consider in the clinic. One other thing, room to room, machine to machine, that some people in our VA will have these nice fancy computers. Other places you have a screen, sometimes it's on the door. We use a near card when we're on call. All of these are different. There's a lot of variability in that. And when I was in residency, and I'm going to try to avoid when I was a resident, but when I was in residency, at our VA, we had the post-op day one room. And that's the room where we worked up all our post-op day one cataracts because it had the best vision. So we always wanted the best chance to get that 20/20 post-op. So all these things take into account when we check someone's vision, it's probably not as reliable or as accurate as we want it to be. And that's just the basis, right? That's the first thing we do in the exam. That's what we care about is Snell and acuity. So with that as a bit of a primer, let's get a bit into the story. So I'll let you know that I spent way too much time on GIFs and way too little time preparing this talk, but I hope they're okay. So what are some things, and anyone shut this out, that we typically try to do when we evaluate a glaucoma patient? Just basic things, like things that you want to measure or evaluate.
Pressure.
Pressure, okay. Pachymetry, okay. Pupils, okay. Okay, and what do you look for in DFE? Where you try the nerve? Okay, we're going to see the clinical examination of the nerve. Okay, RNFL. Any other tests that we typically do? Visual field. And then the little thing we like put right near their eyeball. Okay, so let's go through these. We'll try to do it sequentially. Start with the biggest one, pressure. So getting in our comfort space where we have certainty. IOP is an objective measure. It is something we have absolutely every visit. It's a number. It's something we can feel certain about. And it's based on math. This is the Goldman equation, which tells us what the pressure should theoretically be. And it's actually pretty cool. And I'm not going to get into it now. It's better for an intro talk. But if you know how much of the angle is closed and the rest of the angle is normal, you can guess what the outflow capacity is. You can guess what the pressure should be. And if the pressure is not that, then you have a better estimation of what part of the angle is functionally closed and not appositionally closed, and vice versa. So if you know a patient has a pressure of 40, you can guess what their trabecular and non-traditional outflow capacity should be. So that's cool. That's math. That is absolute. I don't know if that's how easy this is. So for our med students and our optometry students, if you're here, again, no wrong, right answer, but just your guess. What do you normally think the normal pressure and pressure range should be? So if your patient says, "What's normal pressure?" What are things that come to mind?
Into 21.
Less than 21. Okay, and then an absolute number. What is the most common normal pressure? Like, where is the middle line? 16. Okay, yeah, somewhere in the range. Okay, so where does this come from? So this all started with a study in the 1950s in the Netherlands, and you'll find that this is of 10,000 people that did not have glaucoma. We'll call them normies. So you'll find a lot of the normal databases in glaucoma, and probably a lot of other places, are from very homogeneous populations, particularly Northern European in glaucoma. So some concerns, limitations there. But 10,000 normies, they found that the average pressure was 15.5. The standard deviation was 2.5. And so assuming a Gaussian or bell-shaped curve, that means that 95% of the population is going to fall within 5 points or 2 standard deviations of either side. So middle is 15, on the other side is 10 to 20. So that's where these numbers come from. Average is 10 to 20 with 15 being in the middle. And then, thankfully, this has been validated in multiple other epidemiological studies. So it does seem to be that the normal population fits this average. However, it is not a Gaussian distribution. So this is the important thing, is that it follows more of a trend towards higher pressure, so especially if you're over the age of 40. So this is a non-Gaussian distribution of pressures in our population. This also ignores, the important parts about normal people who have normal pressure who have glaucoma, normal tension glaucoma, people of high pressure who don't have glaucoma, ocular hypertensives. So the normal pressure that we tend to quote or think about, there's some significant concerns and limitations to it. And then physiologically, pressure varies a lot. There are many things that can affect or influence pressure. I'm not going to go through all these, but just to hit a couple highlights. Environment. So it's fall. We just entered a colder phase of the year. Cold weather lowers pressure. It's thought to due to episcleral venous pressure and the venous changes that occur in the cold. Hot weather is the opposite. Interestingly, particularly counter to that thought, seasonally, pressure is higher in the winter across all populations and lower in the summer for I guess, other reasons. Stimulants will increase pressure transiently. Depressants will lower the pressure transiently. The pressure fluctuates throughout the day. Does anyone know when the pressure is usually at its highest levels? Yeah, early AM. Yep, 3, 4, 5 AM. So if a patient tells you that they're getting headaches when they wake up in the morning and it's a glaucoma patient, worry about the pressure being high. John, this is getting well into the weeds. Do you know why it's at the high level at those times? And just prime, it's either because there's more fluid going in or less coming out.
What production goes down, so I think outflow goes down.
Yes, so aqueous production goes down, so less fluid is actually coming in. That's because there's less perfusion to the ciliary body, and that's because your blood pressure is also at its lowest level in the early morning hours, and so you have less blood flow, less production, but your outflow capacity is also at its lowest, so there's far less getting out and escaping the eye. And what happens in the early morning hours is you have a catecholamine surge, an epinephrine surge when you wake up. That's why heart attacks are most common at this time. You go from your lowest blood pressure to suddenly catecholamine surge and you have that imbalance. And so suddenly when there's that surge, you have sudden increase in production of aqueous, decreased outflow capacity, and that's when the pressure goes up. Exertional influences, exercise can transiently increase your pressure as well. Blinking increases pressure by 10, forceful eyelid closing up to 90 millimeters of mercury. So when a patient's squeezing their eyelids, it can really jack up their pressure. All that this and many other things. All that to say, under normal physiological conditions, the pressure is going to bounce all over the place during the day. And if you take a patient who has impaired outflow capacity, so a glaucoma patient, their pressure can be 10 points difference over a 24-hour period of time. So if we're measuring someone's pressure once or every 3 or 4 months for a minute in time, we can't necessarily rely upon that being the most accurate of pressures. Okay, back to comfort, math. So this is the Imbert-Fick principle. It's how we can measure the pressure of a sphere. If we know the force we're applying on a sphere and the size of the thing we're applying the force with, we know the pressure inside a sphere. Now, this principle is the basis for applanation, as many of you hopefully have gathered or already know. And this principle is based on the premise that the sphere is infinitely thin, it's perfectly elastic, it's dry, and it's perfectly spherical. The cornea, of course, meets none of those criteria. So some math people, we'll call them nerds, figured all this out. And so this is how we adjust for the cornea, the human cornea. And this is the Goldman applanator. And what we found is that when the applanation area is 3.06 millimeters, the pressure inside the sphere, inside the eye, equals the force we're applying. And that 3.06 millimeters is when the internal Myers meet. So when we're applanating the internal Myers meet, that's when we've made the correct adjustments so that this calculation is perfect and we know what the pressure is. Of course, that assumes that everyone's cornea behaves the same as this mathematical model. And as you can probably guess, that's unfortunately not the case. So these are some of the sources of error that occur with Goldman applanation, which is the gold standard. We're not going to get into other types. There's concerns, limitations there, but the gold standard, these are some of the possible errors based upon differences in corneas and techniques and patient factors. There's a lot of them. But let's move past that to the more fun stuff, which is the human part of all this, the people taking the measurements. So there is inherent variability, not only among, but not only between, but amongst ourselves when we measure pressure. So these are kind of confluence of multiple studies. This has been validated many times over in the literature. 30% of short-term readings, so that means if I measure pressure and I measure it again in 5 minutes, will vary between 2 and 3 millimeters of mercury. And then if I myself have a repeat measurement of a patient, there is a 3 millimeter range. If someone else measures the patient, there's closer to a 4 millimeter range of mercury between measurements. That means if I measure a patient's pressure at 15 and I go back 10 minutes later, there's a chance it could be 18. Just simply because of reproducibility issues within our gold standard Goldman applanation. This is a study I love. This is from Wilmer. We'll see Wilmer air their dirty laundry a couple times, which I really applaud them for doing. And these are 2 world-renowned glaucoma doctors. I don't know how it was set up. Maybe they have clinics next to each other, but they went in, one person checked pressure on a patient, and then the other one checked the pressure immediately after, blinded to what the pressure was. They did this 500 times. So the 2 of the world's best glaucoma doctors, and they found that 17% of the time, about 1 in 5, their difference in pressure immediately sequentially in the same patient in the same room was more than 2 millimeters of mercury. When it was a faculty and a technician, it was 1 in 4 or 25%. Not that much different, but the best of the best are getting differences of 2 or more 1 in 5 times. So pressure, the gold standard that we apply glaucoma treatment to, everything is based upon it. It's pretty flawed. Okay, so pachymetry, you guys mentioned that as well. So this is from the OATS, the ocular hypertension treatment study. We'll cover this a couple of times during the talk. But this is the first study. This is a very famous series of tables that are utilized, or graphs. It demonstrated that the thinner the cornea, so 555 or less, the higher the risk of converting from ocular hypertension to glaucoma, 36 versus 13% if they have a thicker cornea. So this is the first study, and this is the basis for why we are concerned with pachymetry. John already answered. Let's go with Peter. So Peter, you should know this. What is the conversion algorithm you utilize when trying to determine what the pressure is based on the pachymetry? You got to know this. Gold standard. Everything here is a gold standard. Absolutely.
Not sure.
Okay. Well, I like your uncertainty. Yeah, there is none. There is no agreed upon way in which we account for pachymetry readings. So, there are algorithms out there. They're not validated. There are estimates. So the rule of thumb is for every 50 microns, there's probably a 2 or 3 millimeter mercury difference. That's the generalized agreed upon rule of thumb, but there's no absolute. There's no absolute number that you can rely upon. We just know the thinner, the more it underestimates, the thicker, the more it overestimates. And you kind of go with a variation there. What about the measurements themselves? So this looked at, I think, 7 different common pachymeters out there. You have contact pachymetry, you have ultrasound, you have OCT based, and they found that within the instruments, there's a 5 to 15 micron difference in measurement of the corneal thickness. Between instruments, up to 120 microns. So if we say there's about a 2 or 3 millimeter mercury difference between every 50 microns, that means there's a 4 to 5 or more millimeter mercury difference dependent upon the machine, or at least the way we're going to estimate what the pressure actually is. For whatever it's worth, they found OCT-based pachymeters to be the most accurate. All right, so that's uncomfortable, right? We don't even know what IOP necessarily is or how much we can accurately rely on it. So let's take the next leap and look at the optic nerve. All right, this is not a trick question. So for our students in the room, do you think this is a nerve that looks like it is glaucoma? Does this look like a damaged or diseased eye? No, I see a lot of shaking heads. No. So I think there'd be pretty good consensus. Most people would say, yeah, this looks like a healthy nerve. It's a really small cup to dish ratio. What about that one? What's the cup to dish ratio there? Do they have glaucoma? Is there notching somewhere? Where is there an Arnefeld defect? Be careful, this is my eye. I'm just kidding, it's not. But so I don't know, right? Like I would struggle with this. Yet these kind of photos are what we utilize. Before there's OCT, it was utilized widely in the clinic, still sometimes, but certainly in all of our randomized trials, this is a primary outcome measure is the optic nerve getting worse based on serial photographs. And these kind of issues are what we face. So these are 3 studies from some of the bigger glaucoma trials. All the studies pretty much have something along these lines, where it is looking at the validity and the reproducibility of the expert observers when they're objectively trying to identify optic nerves. And they all come to similar conclusions, which is we suck at it. So this is the results of these 3 studies. The first one, this is kind of a cutesy way of doing it. What they did is this wasn't for the trial itself, but they took the expert observers and they gave them a series of optic nerves of the same patient in non-chronological order and asked them to guess which nerve was getting worse. I mean, if the nerve was progressing, which was the progressing photograph. So look at the same patient, 5 different photos from 5 different years, which is better, which is worse. And 40% of the time, so upwards of half the time, the one they thought was getting worse was actually the baseline photograph. Again, these are experts. The second was from the Advanced Glaucoma Intervention Study, or AGES. There was consensus that there was notching only 25% roughly of the time. And 42% of the time, more people disagreed than agreed on whether there was any notching. Again, these are our gold. I need to stop using that word, but these are the best of the best, and these are the studies that are defining how we treat glaucoma. This is from the ocular hypertension treatment study again, OATS. In order for a patient to be defined as having progressed to glaucoma from ocular hypertension, which is the primary outcome measure, it was either based on a new change in the visual field or based upon progressive optic nerve cupping on the serial photographs. And more patients, so the majority of patients converted to glaucoma in the study because of optic nerve photograph changes. This is from that study. They found between 20 and 33% of the time an optic nerve that was thought to be progressive. Later, they disagreed on that. So again, these are our big studies. These are the best of the best and they can't even agree on whether a nerve is getting worse or not. Okay, so we are not necessarily convinced about pressure. We're not sure about the nerve. What about gonio? So I don't have much. This is the only slide on gonio. One study I found showing that in a large Medicare, Medicaid population, only 45% of patients newly diagnosed with glaucoma had gonioscopy within an 18-month period of time. So we're not great about doing gonio, at least about documenting it for those kind of purposes. But this is a cool study where it took a series, I think, of 20 stock gonioscopy photos and asked 5 experts to draw the different structures. So the iris root, the ciliary body band, scleral spur, trabecular meshwork, and the cornea. So all had the chance in a standardized environment to estimate what the different structures look like. And these are the outcomes. Suffice it to say that there was not good agreement on any of them, especially the location and size of the ciliary body band and the scleral spur. And this is in an ideal sterile setting. This isn't looking at a patient in the clinic while they're squirming, while the pupil is intermittently going larger and smaller based on where your slit lamp light is located. You know, this is as good as it gets. And even then, experts can't necessarily agree on the anatomy they're looking at. So gonioscopy is vastly important. 100% of patients who are newly diagnosed should be getting it. It should be done serially. I'm not the greatest at that, but I should be getting better. Having said that, gonioscopy has limitations to interpretation. Anterior segment OCT is going to have an increasing role, but even that can't replace many things we do with gonioscopy. All right, I hopefully can get across several important points today that you take home. If there's one thing though that you remember, if there's one education piece that you can take away and for the rest of your life think of as the most important, it is this. This patient needs to have documentation in Epic that you counsel them on tobacco cessation. So moving on to the visual field. Like IOP, I'm not going to get into the weeds about the technical issues with the testing itself. There are a lot of issues with the positioning of the patient and the visual field that can lead to errors and artifacts. We can discuss that later, but the other things I want to focus on for the moment, and no pimping on this, it is simply the fact that there is no defined, agreed upon gold standard of how we determine if someone's visual field is progressing. There is no standard for which we can base it. There are many different ways of going about it, but there's not one that is a consensus. So most of us use clinical judgment, which is what I think most in this room do, is that we look at the series of visual fields and we define ourselves what we think is progressing or not. This is by far the most common way that people will evaluate visual fields. And as you can imagine, because it's based on clinical and subjective judgment, it's the least reproducible. Now, within the same person, it's quite reproducible. So in the studies, the same person that thinks a nasal step is progressing will more often than not think that nasal step is progressing. However, 2 different people would oftentimes disagree. So I may say the visual field is getting worse. Dr. Sanders or Dr. Har may say it's getting better or it's not changed at all. Those are the kind of issues with the clinical judgment. Events-based analysis is the glaucoma progression analysis that you may sometimes see. It takes a series of multiple reliable baseline measurements and then looks at fields and then compares subsequent fields off of that. So it's an event-based. So it's baseline and is the other one's getting worse. This definitely has merit, but it has some limitations. Limitations being that it doesn't look for subsequent progression because it's always comparing to a baseline. And you have to have reproducible, really good baseline data to begin with. The last one is what's called a trend-based analysis, and this is linear progression analysis. And so linear progression is one of those words like cytokines where very few people understand what it means, but when you say it, you sound smart and no one can argue with you. So if you're like at a journal club and you don't know what's going on, you say, well, they didn't do a linear progression. You're going to win. So keep that in mind. So trend-based analysis uses the visual field index. And I included this slide because this just came out just last week in our journal of glaucoma. Or the ophthalmology glaucoma. And what this does is really cool, is it uses the clinical judgment, so the subjective assessment of expert glaucoma doctors, and found which objective measure most closely correlated with their subjective experience. So if I'm saying this field is getting worse, and that field is not, looking at all the different things we use, mean deviation, power standard deviation, visual field index, all that, which one most closely aligns with what we have? And they found the visual field index. which is this thing here. We see it in different printouts at the VA. We utilize it a lot. And the reason why this is probably the most closely correlated and one that more people are turning to is this is the only objective measure that gives us a trend-based analysis, that gives us a trajectory. You know, we don't necessarily worry about what the glaucoma looks like today. It's what is it going to do in the future? And this one helps project that out. So it gives us the speed and the acceleration. I don't know, but it tells us both things. And that I think is very important in glaucoma. So you're going to see more and more of this. Because there's no gold standard, there's really nothing to compare against with each of these different ways of analyzing visual field. And so that makes any kind of comparison, any kind of new way of saying this is the best difficult to do. So in our literature today, in our literature this month, we're still debating what is the best method, and we're comparing against our own subjective assessments. This is a very busy slide. If it looks overwhelming, it's supposed to be. This actually took way too long to put together, but in red, you see the name of all these studies. These are our major glaucoma studies, and underneath each of them is the method section that discusses how they interpreted visual fields. In AEGIS, the Advanced Glaucoma Intervention Study, it's too big. It's a novel, and so I just included one of their many figures discussing their algorithm and rationale for how they're interpreting visual fields. The takeaway is all of these are different. None of them have any clinical implication. No clinician uses the methodology in these studies to interpret their visual fields. They're just complex. They're insane from a clinical day-to-day standpoint. Yet, this is the basis for the data for the decisions we make. So visual fields are complex, and our interpretations are subject to a lot of variability. The last thing to talk about visual fields is the fluctuations that can occur. So this is a great example from my fellowship. This patient was doing just fine, and then boom, 1 year this happened. And then the next field, it got a lot better. So the visual field fluctuated, and it's not necessarily that it worsened as globally as it we're initially worried it did. But if you follow this new defect, it does come back over time. Not fully, the inferior arcuate is not there, but this fluctuation sometimes heralds worsening, sometimes it gets better. So in the Advanced Glaucoma Intervention Study in AEGIS, when they did serial visual fields, they found those that had a sustained decrease, so sustained progression of visual field, 6 months after the confirmatory the visual field, 55% of the time it got better. 12 months after the confirmed sustained progression in visual field, 40% of the time it got better. So in some of our best data, people's glaucoma or people's visual fields will fluctuate quite a bit. So with all that in mind, with all the concerns with the reproducibility of visual fields, the reliability of our ability to interpret them, multiple studies and a recent meta-analysis of all those studies suggest that you need to be doing 4 to 6 visual fields in the first 2 years, and then 2 to 3 per year after that. 2 to 3 visual fields per year. A study tried to come up with a more reasonable compromise where we can still capture progression, but we can do it in a real world manner. And they said 2 fields a year. I don't know of anyone that's doing 2 fields a year in our peer group, both here and elsewhere. And this is data from the IRIS registry. So we'll talk about IRIS data a little bit later too. So the IRIS is a national consortium of data that's put in voluntarily by ophthalmologists across the nation. It's a lot of big data, and it's a lot of, importantly, real world data. So what are people doing in the real world? Not what are people doing in studies. Real world data, less than half of patients that are treated for glaucoma had a single visual field over greater than a year period of time. So in the real world, people aren't getting that many visual fields. We're supposed to be doing more. It's hard to do. It's time consuming. The patients hate it. Cody, you had one, right? It's awful. And you don't get paid if you do more than one. So visual fields are the absolute, one of the most important things in glaucoma, because it tells us what the patient actually sees or what they don't see. But we aren't necessarily doing it the way it's supposed to be done. Okay. Last thing about this is the OCT itself. So another breath of relief. We've got data, we've got numbers, right? We've got an objective test. So you get an OCT, the patient just has to sit there. You get a scan. If they sit there and do a good job, we get data we can trust. And actually, for the most part, that's true. So the short-term variability in OCT data is very limited. So if you get what you think is an accurate scan on a patient now, go back and do another one an hour later or a day or 2 later, it should be about the same. It's within 99%. So that is very, very encouraging. As I mentioned before, the database for what is a normal or a green nerve comes from Northern European patients. So there's some limitations there. And then normal, the normies, it varies quite a bit. So you can have quite a range in what should be normal based upon just human population and morphology differences. But we have this database that we utilize as ways of quickly interpreting it. So there should be a grain of salt with all that. Okay. Garrett, like Peter, easy answer. How do we define progression in OCT? Only one true answer.
Differently.
Okay. You're picking up on things. All right. So yes, like many other things, there is no agreed upon way of which assessing progression. There are some algorithms that are utilized and we get printouts based upon that. Some people use numbers. Garrett, is there a common number you would think of, like a decrease in this would be progressive? Five. Yeah, I think most people say 5. 5 microns. So the typical range and thickness of the optic nerve is 50 to 100 microns, 100 being normal, 50 being really, really thin. So if we say a 5 micron difference is significant, that could be 10%, 10% of the optic nerve. So you could have a wide range and variation if we use that alone. Algorithms that we utilize currently, including the progression analysis you see when you get a printout of serial OCTs and has the red or the green on the wave, that ignores known age-related changes. So we know that as you're sitting in this room right now, just enraptured by this talk, your nerve is dying. I'm killing your nerve. It's every year getting worse and worse and worse, but the progression analyses do not include that. So one study looked at patients that are normies that don't have glaucoma, and they found that 25% would have been characterized as progressing on our algorithm analysis just simply because of age-related changes alone. So some people may be theoretically getting worse when they're actually just getting older. And then many people may be actually getting worse and we miss it because of issues in our databases or because they have the green disease where their nerve is actually looking healthy, but is truly progressing. So without a known, defined, reproducible way of determining progression on the RNFL, it, like visual fields, leaves us to a lot of subjective assessments. Unfortunately, the machine itself also has some issues. So I'm not going to belabor any of this, but just to show you briefly, and you've seen all these if you looked at scans before, there's segmentation errors that can occur either anterior, posteriorly, or just segmenting the borders. There's scanning artifacts where it can be decentered, so it's not a reproducible scan. It's different than it was the time before. That's more of a technical issue that we can do and improve upon. Now, let me just say as one quick teaching point, if you're worried that an OCT is progressing, but you're not certain if it's accurate, you can repeat it. Just like in that moment, just send them right back in another one. You don't have to worry about waiting or anything like that. You can just quickly go back and get another one and try to see if it's reproducible. Scan quality can be down for a variety of issues, including media. The RNFL can be truncated or missing portions of it. You can have actual ocular issues like a vitreous attachment, peripapillary atrophy, a staphyloma. This is kind of cool, myeloid RNFL. Other kind of macular pathology can do it, like epiretinal membrane or macular edema can cause artifactual thickening. So there's a lot of things that can lead to errors in interpretation. I mentioned green disease. This is one of my favorites, mostly because of this is something we did I had a very enthusiastic mentor and fellowship, Dr. Sanjay Israni, and he just loved to teach and he loved to get excited about it. So he'd be like, look at this, Danny. This is getting worse. This is getting worse. This is getting worse, right? So his glaucoma is progressing. Like, yes, right. It's getting worse. And you're like, yeah. And so what this patient had, and we wrote this up, was relatively uncontrolled uveitis and ocular hypertension. And so in these scans, this is a patient while they have a subclinical papillitis. This is after they underwent systemic immunomodulatory therapy, and their IOP improved as well. So their disease from a glaucoma standpoint actually got better controlled. But because their nerve thinned out because of edematous or uveitic edema, it looked like they were actually progressing. This is not something that our progression analysis actually is getting the opposite. This is a human-based judgment that we would have to do. We can't rely upon a scan to tell us what's actually occurring in this patient. So our machines are great. There are limitations to what they can provide us. Probably less limitation than our own assessment of optic nerves. But this isn't something that we can just full-heartedly lean into. based upon the known variability between scans and over time and all that kind of stuff, this is a conclusion of a recent study that used computer-based AI algorithms and all that kind of stuff that I don't understand, looking at a database of hundreds of thousands of scans to find that if we want to determine, moderate and of course to rapidly progressing glaucoma over a short period of time, so over 2 years, is this patient's optic nerve progressing, you'd need 7 scans. 7 scans over 2 years. So like everything else in glaucoma, we aren't doing enough to detect what is at our current technological capacity, the disease progression. And we can't. I mean, I don't think it's currently within anyone's scope to be doing a visual or an OCT on every patient, every visit, or a visual field 2 or 3 times a year. But that's really kind of what we need. Okay, so let's kind of summarize the end. His Snellen acuity is probably fine within a range of 3 lines. His IOP, we are absolutely sure we know what it is with a range of 3 or 1.5 on either side, and his central corneal thickness, I mean, maybe. Optic nerve, I don't know if I'd ever agree with myself. I certainly know that my colleagues would disagree with whether it's getting worse or not. He may have a visual field scotoma, but we need to confirm it, and then it could be fluctuation. We'll have to wait and do several more tests before we're sure that's the case. But we should be doing more tests, but we'll have to do a few more. And then RFL, yeah, it may be getting worse, but we need to do quite a few more scans before we're certain. So diagnostically, we should not be certain of anything with glaucoma and have a lot of bit of doubt about ourselves and about our measurements, which is comforting, right? We should feel good about this. All right. Let's focus for a few minutes on what to do about it. So let's just forget everything and say we are comfortable and confident that Ian has glaucoma and we're going to treat this patient. Nick, what is your IOP target? What kind of a reduction are you looking for in pressure? What is the correct answer?
It depends on the patient, but generally, let's say 20 in the ballpark of 20–30%.
That's great. That's a perfect answer. And I hope you like if it was, it's the target. They're missing the target. Okay. Anyway, so this is the data from our largest glaucoma trials, and this is the IOP targets that they were trying to hit. So this is what they were trying to get to. Ocular hypertension treatment study, 20%. Collaborative normal glaucoma treatment study, 30%. So when you say 20–30%, you're hitting most of them up. For those of you that are trying to study for OCAPs, and I don't know if we have any of our, we have a board test taker in here. So boards are tomorrow. Please give our first year fellows a pat on the back if you can. For those that are taking tests, one way to remember this is normal tension glaucoma usually has the lowest pressure to begin with, but has the most stringent lowering criteria. So stringence is 30%. Ocular hypertension treatment has the least severe glaucoma and also has the least stringent criteria. So 20% OATS, stringence is 30. Ages, and then a lot of the subsequent papers actually used a numeric, less than 18, less than 50. We also stick with 18, but it's all over the board. Do we pick a target that's an actual number? Do we pick a target that's a percentage of decrease? I don't know. Okay, so with that in mind, let's actually go through the 3 mainstays of treatment, starting with medications. So our patients don't use our medications as much as we think they do. Even if we don't think they use them that much, they probably use them less. So this is across the board, right around the number 70%. Most studies will demonstrate that's compliance. So patients are using their drops 70% of the time. Now, keep in mind, these are studies, for the most part, that are prospective studies evaluating whether the patient are taking their medication. So the patient is enrolled in the study saying, we are looking to see if you use your medicine. So it's not a surprise. They know that they're being monitored. They're given prescription bottles that like you have for pills that have electronic sensors that every time you open the cap and take the eye drop out, that's how it measures whether you're taking the drop. So it's a weird looking little machine. So it's sitting there, oh, this weird looking machine, I'm being tested whether or not I'm taking the medicine. It's the best conditions possible. Still 70% of the time patients take their medications. Then there's a lot of reasons why this may be, and we'll go into just a couple of them. But one to keep in mind, medication regimen, the more medicines, the more doses you give them a patient on average, the less they're going to do. So the more complex, the more you give them to do, the harder it's going to be. So simplify as much as possible. There's patient-related factors. They have arthritis. Do they have a tremor? Do they have visual impairment? Can they even see where the eye drop tip is? There's a lot of things that go into that we don't think about. Provider-related factors. So this number 70% is eerily and appropriately similar to compliance rates with systemic hypertension medications. And the reason is both of these are asymptomatic diseases that get worse slowly, that have side effects with their treatment. So on a day-to-day basis, it's harder for a patient to take medicine than it's not. They don't notice that they're going blind, but they sure do notice the hassle, the cost, the discomfort with using an eye drop. And so the relationship we have with our patients, the more we can have an impact on the reasoning why we need this, the more we can demonstrate how valuable it is, usually the better we can do. And the opposite is true as well. This study just came out last month. This is near and dear, I think, to all of our hearts. So this looked at electronic prescribing patterns of patients at a single academic center over a 6-week period of time after the prescription was written. And they found that a third of patients did not get their medications. And the reason for that third, all 33% of the patients, was not because they didn't pick up the prescription. They all did. It was because there was a prior authorization issue. There was another issue with the insurance, or the pharmacy didn't have the medication in stock. Third of patients because of issues with our system. So there's a lot of reasons why patients can't get medications. This is data from here. This is UK based. So what we did is we built this little device that would measure the force required to squeeze eye drop bottles. And we found that the variability, oh God, yeah, here we go. Show and tell. Okay, so this is like that weird guy who's like, here, take your hand and feel my things. This is a bunch of different eye drops that are available. And you can just like look at them, you can get them out, you can feel them, but what you can tell is there's a variability in how hard it is to squeeze the bottles. And so we found that there's a 7-fold difference. So one medication can be 7 times harder, another medication can be 7 times easier to squeeze. Because of how hard or easy to squeeze, it's how quickly eye drops come out. And we also simultaneously measured the grip strength of patients, so how well they can actually squeeze it. And we found that for a significant number of our patients, less than half, but a significant number, their grip strength is less than what it takes to squeeze the bottle. Some of our patients can't even squeeze the bottles, especially the harder ones. And this type tends to be the more difficult one to squeeze. The other study we did was looking at the number of eye drops that come out of the bottle. So we used a standardized pressure to just measure eye drops. So in a more objective, controlled manner, how many eye drops are there in a bottle? And you would think it'd be the same, not even close. It's all over the board. So these are the commercially available Timolol and Timoptic eye drops here locally in Kentucky. Based upon the day and where the patient goes to get their medications, they could get any of these. You know, they don't get to choose which manufacturer. They can get any of these. These are all 5 milliliter bottles, same volume, same volume in each, same volume, same medication. And we found that the range of drops was anywhere from 123 to 209 per bottle, which is a difference between 25 and 43 days of availability. Same medication, depending on the day and which manufacturer they get. So that's a big issue. That's one that we don't talk about too much, but there's a lot of manufacturing issues with eye drops. Because of this is awesome. And I don't know if everyone knows about this. Because of this, about 10 years ago, our eye care providers all got together with our state legislature and did something great. They passed a state law, and this state law is specific to eye drops. This deals with no other medications. Specific to eye drops, patients in the state of Kentucky can get their refills early. So a 30-day supply, they can get it 25 days. A 90-day supply, they can get it 80 days. No cost to them. The pharmacy has to provide it, and the insurance has to cover it. So there's a state law providing that. And many pharmacists may not necessarily be aware of this. In the law is that you have to write it on the prescription. I found that's not the case. You can have the patient tell the pharmacy, or you can call the pharmacy. But if you do write on the law or on the prescription, this KRS code, it works a little bit easier too. I don't have this memorized. KRS is the first 3 letters of all state laws. I forget what it stands for, but if you just Google KRS eye drops or KRS Kentucky eye drops, it'll come right up. And so if you're ever in a situation where a patient's running out just a little bit early, you can help them out with this. Okay, so let's say our patients are actually using their drops. Does it help? Is it necessary? So this is back to OATS, ocular hypertension treatment study. So these are patients who had eye pressure roughly 20 to 30 that did not have glaucoma. Half got treated with a pressure target of 20% reduction, half got nothing. They found at 5 years of those that were untreated, 10 progressed to develop glaucoma, which is the earliest signs of change on a visual field or the earliest signs of change in the optic nerve. If they were treated, it was only 5%. So for our statisticians in the room, does anyone know, we'll start with relative and then the absolute, what the relative risk reduction is with this data, 10 versus 5? 50%. There we go, love it. So 50% difference. So if you treat an ocular hypertensive, there's a 50% chance compared to not being treated that they won't develop glaucoma. That's huge. That's the number that's quoted, 50%. What's the absolute risk reduction? 5%. Okay, and do you know what the number needed to treat would be based on that data? 20. Yeah, very, very good. Okay, so the absolute risk reduction is only 5%. Number needed to treat is 1 over 5%, 1 over 0.05, so 20. So that means even though there's a 50% relative reduction in the incidence of glaucoma if you treat a patient with ocular hypertension, at 5 years, you would need to treat 20 people unnecessarily for one to get that benefit. So that's pretty incredible data. Now let's follow oats out. We have it at 20 years. This just came out last year or this year. So 20 years of trial data. Now, this data is a bit muddy because after 7 or 8 years, they unrandomized patients and allowed the prescriber to treat at their own discretion. So some of the people who are untreated got into the treatment group. So it's a little bit muddy, but they found between both groups, the incidence of developing glaucoma is 43% in the treatment group, 48% in the non-treatment group. So it's a fair amount that went on to develop glaucoma, and I'll explain why quotations, but it's not that big of a difference between whether they got treated or not. And I say develop because, again, like before, more than half the patients who develop glaucoma is based on their nerve getting worse, and 20 to 33% of the time, the experts couldn't even agree on whether the nerve was getting worse. So this is whether or not they just developed the early signs of glaucoma. Only a quarter of all patients enrolled actually had any visual field changes at all. So only a quarter of patients had visual symptoms, visual problems from the glaucoma. And this is just the earliest sign. This isn't like debilitating visual disease. This is their mean deviation, power standard deviation changed a little bit. You were more likely to die in this study at 20 years than you were to develop glaucoma. So medications, they can work. They definitely can work. There's some concerns. All right, let's go with SLT. You have any seniors? We have Bader. Okay, sorry, John, I hate to pick on you, but you've been doing quite a few SLTs now. You should know the answer. So what are the parameters that you use? The ideal SLT parameters. So how much of the angle do you treat? How many shots do you put in? What power do you use?
You can get like 100 shots in. As much of the angle as you can see well.
Okay. Anyone else do anything different? That's very reasonable, I think.
Forget the energy settings.
If I said I do 80 instead of 100, or I do 120 instead of 100, would you scoff at me?
I
said I do
go until you get the champagne bubbles.
Okay.
50% of the time.
So you want champagne bubbles 50% of the time. Okay.
I can't, as far as the numbers, I forget.
So that's right. Wrong. No, that's not. No. So yeah, like everything else, there's no agreed upon standard for any of this. This is a review and meta-analysis of all the data and the glaucoma literature as it relates to SLT. There is no consensus on the number of shots, the amount of the angle to treat, whether you go based on number of champagne bubbles and whether you want 50% champagne bubbles or 25 or 100%, whether you treat low or high power or number, the absolute number, the power per shot or absolute total power. Whether you titrate your treatment based upon the amount of pigment in trabecular meshwork. None of those things is defined in this treatment that we utilize on a very frequent basis. So lots of room for improvement there. Looking at the outcomes, so the success rate. So this is the LIGHT trial. This is a standardized prospective randomized trial of patients that have untreated glaucoma that were randomized to SLT or other treatment. And they found drop-free control in these patients 75% of the time. Most of the patients after just one SLT. 3/4 of the time, patients don't require drops after SLT. That's great. This is IRIS registry data, so a little bit more muddy data, but this is better real-world comparison. Found the success rate overall was 37%. Now, if your pressure is more than 24, the success rate goes much higher, and it actually is pretty similar to the LIGHT trial. But if we take all comers, all patients that get SLT with glaucoma who are on drops, aren't on drops, have mild, have moderate, have severe, if we take every patient who gets an SLT, success rate is 37%. It's a lot lower than I usually quote my patients. Okay, lastly, surgery. I mean, thankfully, like we get the fun stuff that works, right? We get to actually put our hands in our patient's eyes and we're going to make a difference. So this is from the 2 versus TRAB study on the left, and then the primary 2 versus TRAB study on the right. The 2 versus TRAB study was done in the 90s. This is the 5-year data, which came out in the early 2000s, just comparing the 2 different surgeries. They found that the success rate, I'll go with failure rate at 5 years, 47% if you had a TRAB, 30% if you had a tube. Third to half of our patients fail after their surgery. These were patients, so at the time of the study, tubes were a bit controversial. So whether or not they should be utilized more widespread, they're kind of used in refractive glaucoma. So these are patients that had sicker eyes to begin with, because those are the ones that went enroll in this initial study. So that's why they did the primary tube versus trap studies. This is more standard, normal patients that need incisional surgery. And they found that the failure rate is actually about the same. In fact, it's a little bit higher in the tube group than it was in the initial study. So this is our best data. These patients are failing their surgery at a really, really high rate. I actually want to get past it. So this is all sobering information from those studies that really isn't, it's glossed over. It's not mentioned much, but some kind of not so fun and exciting outcomes that are related to it. So it's all, these surgeries have their concerns intra postoperatively. The patients are still on average taking over medication, over one eye drop at 5 and 10 years after their procedures. So it's not as curative, or I guess, or stabilizing as we'd like to think. This is 2 other studies that count subsequently. These looking at 2 different types of tubes, AMEDs versus barbells. So we'll forget about trabs, which seem to fail at a slightly higher rate overall. But when we're looking at 2 different types of tubes, what is the failure rate of that? And so this AMED versus barbell on AMED barbell comparison, 2 head-to-head trials that came out near simultaneously. When they pool the data together at 5 years, the failure rate, 49% in the AMEDs, 37% in the barbells. And 16 and 8% had to go on and have secondary surgeries to control their glaucoma. Most patients are taking, on average, closer to 2 than 1 eye drops. Back to the real world. So this is from Wilmer, our good friends there that are, again, willing to tell us some of what happens to them. And they looked at their trabs over a 2-year period of time, 2014 to 2016. They found that 10%, 1 in 10 trabs went back to the OR within 6 months for a secondary glaucoma procedure, a quarter any time after the surgery. So at that point, within 6 years of their surgery, a quarter of them are back in the OR for a secondary procedure. This is from the IRIS registry as well, looking at incisional glaucoma surgery, so trabs and tubes. And if we look at the real world data, over a quarter of patients with glaucoma, with POAG that have an incisional surgery have to have a second one within 5 years. 1/4 of the patients who have glaucoma surgery have to have a second within 5 years because it failed. That's the real world. So our friend, Ian, first off, we don't even know if he has glaucoma, right? And if we think we need to treat him, there's no gold standard for what we're trying to do as far as a target. If he uses his medications, we know there's going to be issues with his compliance. The SLT could work. It could work really well and keep him off eye drops, but we are not absolutely certain what the best way to go about it is. And our success rate is a lot lower than I think most of us would consider. If they have an incisional glaucoma surgery, the failure rate is pretty high. And there's a chance they're going to need more surgery. And there's a chance that they could actually get worse instead of better. And then if they have early disease, we may not even need to treat them. We may be unnecessarily treating them. So there's things that make us question everything we're doing. And so this is the last couple of slides I have, and I want to give some time in case other people had comments, but what do we, what's the point of this? Why did I make us all depressed? And so I have 3 take homes. This is a quote from Daniel Kahneman. It's one I keep close to my heart. He is an award-winning economist and social psychologist. In fact, he's really the founder of the field of social psychology and behavioral economics. And what he did is a lot of studies demonstrating how we go about making judgments and suggesting very strongly that the way we do it is not how we think we're doing it. We're much more subjective and prone to bias and errors than we think we are. And so this is one of the quotes he said I love is, it's wrong to blame anyone for failing to forecast accurately in an unpredictable world. So we shouldn't blame people for trying when they're up against all kinds of odds. But when it seems fair to blame professionals for believing they can succeed in an impossible task. So the confidence levels we create around ourselves, if they are out of proportion to what they should be, that's the thing we should be concerned about. So absolute certainty, certainty is absurd. So when we're treating glaucoma and maybe more broadly, when we're looking at the world, we shouldn't be thinking about it as black and white as we do. We should be allowing room for gray. Another kind of way of thinking about this that I don't do a good job of, but I like to pretend to, is one of the definitions of the difference between knowledge and wisdom. So knowledge broadly based is what you know. So a lot of you in this room are gaining knowledge at a rapid rate. And then some of you after this weekend are going to try to get rid of that knowledge very quickly with some substances. Wisdom is increasingly being aware of the things you don't know. And so wisdom isn't necessarily what you know, it's knowing what you don't know, it's an experience and humility that comes with time to recognize that the more we do know, the more we realize there are things that we don't know in a much greater proportion. And I think that pertains to glaucoma right now. Secondary thing is that we like to think of things in absolutes. It's better or worse, it's above or below. And glaucoma, that makes it very easy when we're very time compressed and we can't really spend the amount of mental and physical energy it takes to think about this in much greater terms. And we can't describe it to our patient and get the buy-in we need unless we're very certain in what we tell them. And to some degree, we have to do that. I mean, that's just the real world. We have to try to work in this kind of environment. But in the back of our minds, if we can think more in gray instead of black and white, I think that will do better by our patients, because glaucoma is always getting worse. It's never stable. And no matter what we think about it, our patients are always progressing. It's just at what rate. And I guess this would tie into the very last point is, this is, I think, what makes the treatment of this disease, and I'd love our other docs to share if they have it, some of the best and worst moments in your life is because of all this uncertainty with glaucoma, you have to treat a patient and not just a disease. And you're doing better by them if you walk alongside them, you get to know what's going on in their life, and you try to tailor your therapy to them as a person, because there's a person who has 6 months left to live and may not need what you need. There's a person who has 40 years left to live and they need more than what you're able to give them. You're going to harm more patients than you think you are, even though you're trying to help them. There's going to be some patients you do your best to harm them. They got 6 surgeries in and they actually do okay. So as much as you try to hurt someone, they could be helped. As much as you try to harm another, or as much as you try to help another person, they can get harmed. And so the way in which you get through all this is remembering that you are part of a team working side by side with your patient. You're their doctor. You absolutely have a power dynamic that's part of that, and you need to recognize that. But it's not as as black and white as you think it is. You're working and walking alongside them. So yeah, that's all I had. I'm sorry. I think that was all over the place, but I hopefully made you feel uncomfortable enough to try to question things and to recognize that the uncertainty is actually a positive. So comments, concerns, questions? Yes. Yes, so I avoided those. So yes, I think across the board, so the comment was, what about MIGS? So I didn't talk about corneal hysteresis, which is something that's becoming more common when we're trying to evaluate pressure and risk factors for IOP and fluctuations. It's something that I think is going to have a much larger role and is evolving. Anterior segment OCT when we're looking at the nerve. And then when it comes to surgical treatment, definitely MIGS. So going away from these big incisional surgeries with high complication rates and still have high reoperation rate, and doing something that's more minor that has a lower complication rate may not get you as far, but goodness, if 25% of our patients who have a tube are going to need a second procedure in 5 years, why not do a MIGS first and a tube second instead of 2 tubes? So that's a big part of a paradigm shift in how we're treating glaucoma. The data is still very much evolving as to some of these numbers that we already talked about with tubes and trabs. So they aren't a panacea. They still have issues, but I think most people in the room would jump to a MIG before they would a tube for most of their patients.
Thing is flashing, it's gonna show up here.
Oh, thank you.
Any particular type of MIGS are you thinking superior?
Well, one thing I was going to put in my talk that I didn't, this is one of my favorite quotes. It's from the movie Anchorman. And so it's 60% of the time it works every time. And I feel like that's the way glaucoma is. So in my hands, you get a lot of that. I think a lot of us here are going to more canal-based procedures. So canaloplasty and Omni, which tends to be a little bit more robust than say a Cahook or a Hydrus, which is better probably than a iStent. So kind of in that range. And then mixing and matching, doing 2 or 3 at a time instead of just 1 for patients you're a little bit more worried about may get more bang for your buck.
Did I misunderstand, or did you say earlier about going to ask? Are you saying we should be doing that serially?
Yeah. I mean, the angle configuration, especially in phakic patients, angle configuration can change over time. So if you have a patient who's stable and comes in with a pressure spike of unknown etiology, again, I did, and for all this, I am on a pedestal, but I'm really preaching from the choir. I am not, I am very much susceptible to this more so than everyone else. So this is not me trying to proselytize onto you, but if you're doing a good job, if a patient comes in with anything that's worse unexpectedly, repeat gonioscopy, especially if they're fake it, because they could have progressive angle closure that you're not noticing.
Especially if they're hyper.
Yeah.
Lens changes.
What are some terms you use with patients when you give them a diagnosis of glaucoma, considering all the uncertainty that you have in the back of your mind? I know a lot of patients seem to be under the false impression that their glaucoma can get better, for example, or this procedure will cure my glaucoma. Like, can you give some examples, some work?
Yeah, and you know, this is the thing, is you get into your career, you're going to find you have phrases you use. And the nice thing about them is you've developed them, and they seemingly based on feedback from patients perhaps work. The nice thing is, like, these are like pre-scripted talks in your head, so you can start saying it while you're doing a secondary task perhaps. So it helps with patient flow. But in that kind of talk that I give to patients, you know, if we're talking about irreversible nature, like it's not going to get better, it's only going to get worse. We have to stop it in time. You know, depending on how much information they want or how savvy they are, I'll say, you know, this is a disease of a nerve, and that nerve is part of your central nervous system. So it's part of your brain. And so you can think of it like a brain disease. So if someone has Alzheimer's, it's not going to get better. If someone has a stroke and can't move their arm, it's unlikely they'll ever be able to move their arm again. If someone, you know, breaks their spine, a football player, they're not going to walk again. So the same thing with this. When nerve tissue dies, it does not regenerate. So we are stuck where we are, and we are just trying to keep it from getting worse. And so things like that, like it, and reinforce that every visit. We're trying to keep it from getting worse. All of our interventions, trying to keep it from getting worse. You know, when you do an SLT, patients like, this is like LASIK, right? Like, no, this is not like LASIK. Thankfully, when they come from retina clinic, it's like, this is not PRP. Like, so thankfully that's the opposite. But most of them are thinking about LASIK. And then if you're doing a glaucoma surgery, they're thinking about cataract surgery, right? They're like, you're going to make my vision better. We're like, no, unfortunately, it's probably going to get worse. And then if you're doing glaucoma and cataract surgery, like, yeah, part of it's going to get better, but that's only a small part, you know, and so you have to tailor communication to those kind of things. When you're talking about pressure and the uncertainty with that, you know, one thing I'll try to do, because patients and me too, we hang our hat on what the pressure is today. Like that's one of the most anxiety provoking things. The pressure is 2 points higher, the pressure is lower. You know, I always try to tell patients, this is what your pressure is at this moment in time. At a moment in time 3 months ago, it was this. Let's take this with a grain of salt. You know, I'm excited that's a little bit better. I'm not too worried it's a little bit worse. You know, if I am worried, we're going to come back and do it again. You know, so, you know, trying to tailor or to temper expectations as much as you can with those kind of things.
I can say a few things about that too.
Yes, please.
Yeah, so I try to be a little more hopeful and positive in a depressing and not hopeful disease. But when someone, especially if they've had, you know, visual field loss, it's progressive, and you can say, wow, we're losing the game here. One thing I can say to them is, if we stabilize this and your blind spot doesn't get any worse, your brain is going to learn how to look around this blind spot better. So if you narrow it, if we stabilize the disease and you can adapt to this blind spot, you're going to be less frustrated. That's a really hopeful thing for people to hear, you know, like, yeah, you're going to feel better and be less frustrated if we do a good job. And I think that's fair to say, and I've seen that in patients. And the other thing, if someone comes in with just a sky-high pressure of 40 or 50, and their optic nerve is just like screaming, and you get the pressure better, some of those nerve fibers that are just, they're stressed, but they're not dead. It's like Princess Bride. They're nearly dead. Some of those fibers are gonna rally a little bit if you get the pressure down. So I think it's fair to say that Dr. Stegman in South Africa, he worked with a South African population with pressures in 40s and 50s, and did some beautiful studies of the optic nerve, and actually did show the nerve blooming and looking a little better after intervention. So I'm a glass half full person, but I try to use that language with my patients because I think it is important to give them some hope.
Thank you. And Dr. Sanders is so good at that. Like the transference, countertransference that occurs in a patient interaction, they're going to pick up on your cues and body language. And if you're doom and gloom, that's, you know, and vice versa. So I think that the attitude and the way you script and tailor your therapy, your conversation is so important. One other thing I if I'm doing a good job, I try to do is ask the patient, like, what's your vision like? What are things in life you struggle with? What are things you want to do and you still can do? And then kind of talk about that as goals. It's like, well, I love cross stitching. I love reading my Bible. Okay, we're gonna do everything we can to make sure you can still do that, because you can do it today. So our goal is to keep that for you as long as you can. And so, you know, those are ways you can talk about that too. Dr. Pearson.
More likely to die than a visual field progression. Depression. What's the most common cause of blindness in a patient with glaucoma? Macular degeneration. So, you know, you can add that onto your doom and gloom, that you're far more likely to go blind from macular degeneration. I don't really care about that. You know.
And I'm not here to talk about that. That's why I'm sending you to Dr. Pearson.
I think that's still the case. I don't actually know that. So the very first research project I did at UK was on statistical analysis of visual fields. And this is just a good story. It's not anything. So I had somehow it got selected for a paper in Vancouver, and I had to go give this paper in Vancouver. I didn't really know what I was talking about. And Tom Smith said, well, nobody else will understand it either. And if they ask you a question and you don't know the answer, just answer the question. Just answer another question. And so that actually happened. This guy asked a question. I had no clue what he was talking about. So I just answered a different question. We both stood there stunned looking at him. I don't know what that was talking about.
Just experience-wise in our clinic, what percentage of patients do you find yourself not believing the tonal pen pressures, going back and doing applanation yourself?
100%.
Glad to hear that.
And if it's not here, it's even higher.
Okay.
Good. I would like to say that, sometimes I question my own sanity for choosing to do pediatric glaucoma, but he's making me feel a lot better.
And 50% failure on is great, because there's some days if there's no re-op, there'd be no op at all.
Wow.
One glass up full. Okay, well, thanks everyone. Have a great weekend and start to fall. It's going to be pretty.